Thank you. Good afternoon. It's a big hall. I feel like I'm giving a plenary talk, but hopefully all will be fine. So I'm going to talk about actually the 2010 implementation of the 2010 guidelines, which of course we are far advanced beyond that. But I think the results of the study that I'm going to talk about are much relevant even today for the new guidelines that we have. Just as a background, I'm sure all of us in the room know what the 2010 guidelines were, and this included provision of lifelong ART to HIV positive mothers who were in need or eligible for treatment at the time. But there were also two options for ARVs, that is provision of ARVs to those who needed just to have medication for prevention of mother-to-child transmission, what was called option A, and provision of SDT as a backbone, and then extended or prolonged ARVs for the child. And then the second one was option B, which was given to the mother during pregnancy until breastfeeding stopped. The implementation of these options were considered efficacious enough to significantly lead to reduction in mother-to-child transmission. And at the same time, the Global Fund also saw the need to scale up efficacious regimens and therefore reprogrammed or supported countries to reprogram existing funds in order to encourage that scale up. So it's against that background that UNICEF worked in collaboration with the Global Fund to assess how countries had managed to adapt the guidelines and to also implement them at the service delivery level. So this was a rapid assessment. It was not something that was too extensive or very scientific, but it was meant to gauge essentially the operational issues that countries were facing and how UNICEF specifically could be able to support countries to address some of those concerns. So in terms of the data and the methods, 4 countries participated, or those that accepted to participate. That is Tanzania, Zambia, Malawi, and Lesotho. And the assessment was conducted between November 2011 and February 2012. We particularly focused, it was more qualitative, focusing on document reviews, key informant interviews, and also assessment in 10 facilities in each country, just to get a feel of how implementation was going on, and particularly also addressing the geographic location in terms of urban, rural coverage, as well as the level or type of facility. So we did conduct some structured interviews around the topics listed there in terms of availability of the guidelines themselves, staffing levels and training, availability of essential medicines and other essential commodities, and also lab tests, as well as a sense of how countries had adapted their record-keeping systems in order to be able to incorporate the new recommendations from the guidelines. So we did abstract also some data just from the 10 facilities in each country. This was not comprehensive, but it gave us an indication of how countries were really dealing with the issues of changing records. So we abstracted information just on a few select indicators on maternal ARVs, on CD4 testing, on uptake of ARTs or of HIV testing, as well as uptake of ARVs for children, early infant diagnosis, and cotrimoxazole within 2 months. So I'll just then give you a run through the results. It's not easy to summarize results that came out of 4 countries that involved over 100 people that we talked to, and of course the rest of the information that we are able to read in just 15 minutes, but I'll try. So in terms of adoption of the guidelines themselves. And the 4 countries chose different options. 3 of them, Tanzania, Zambia, and Lesotho, chose option A, while Malawi chose option B, and which they modified really to call it B+. And I think we are all familiar with the Malawi story of the reasons for that. But essentially, the choices were based on comparability of the efficacy of the 2 options, A and B. They were also based on the cost, whether it was looking at the cost in terms of the different scenarios that the countries looked at, the feasibility of implementation or the ease of rollout, as well as the health benefits. Malawi, on the other hand, decided to rename the option B to option B+, and decided to provide lifelong ART to all HIV positive mothers, irrespective of the CD4 count. And the reasons for these are some of the reasons was the potential benefit of, or the potential health benefits. But in addition to that, it was really driven by the MCH context in the country. High fertility rates meant that women were having short birth intervals, so they did not see the need of starting the women on medication and stopping, which could lead to other adverse effects. So instead, they went for lifelong so that that interruption is not there. They also looked at the consideration of the potential benefits of preventing sexual transmission, particularly among discordant couples. And they also looked at the fact that ANC attendance was very high, but the fertility deliveries were low. So they would be able to capture the women as soon as they come to the facilities. So we know that the capacity to provide services is very important, particularly in the context of rolling out guidelines. So one of the components that we looked at was the training that the service providers at the health facilities that we assessed had received. So that chart just gives us an indication of the training levels amongst antenatal care staff that we were able to talk to. And generally, we see that the training was very high in Zambia and Tanzania, and Lesotho and Malawi were on average, even though we know that Malawi was doing quite well despite that. And this is mainly because of phased approach to training, in which they were taking a few staff at a time without disrupting service provision at those facilities. Training in pediatric HIV was particularly low across all the 4 countries. And this is not surprising given that what we observe even today with the new guidelines. We also looked at the capacity to provide essential tests such as maternal HIV tests, CD4 count for those countries that had chosen option A, and early infant diagnosis, that is HIV testing within the first 2 months. Generally, we see that maternal HIV tests were generally available across all of the sites that we visited, but CD4 was relatively available, and HIV testing for infants was almost always by transportation to central laboratories. And this is something that is commonly occurring even today and impacts on the delivery of pediatric HIV care and treatment services. We also looked at availability of essential supplies and medicines, which is important because without this, then the service would really not be complete. Again, overall, supplies were generally available with a few stockouts in a few facilities that we visited. And again, the medicines that we looked at were in relation to the type of option that the country had chosen, so it varied from country to country. And then I mentioned that we abstracted some information on coverage of key PMTCT services. And this chart just shows us the levels of maternal HIV testing, CD4 testing, and maternal ARVs uptake, as well as lifelong ART. So what we see in this chart is that generally uptake of HIV services amongst pregnant women was quite high, with the exception of Tanzania, where it was only about 2/3 of the women. CD4 was also relatively okay, depending on what the country had chosen as the option. But there was a problem in Tanzania because the registers had not been adapted to incorporate some of the key elements for CD4 testing, and therefore this information was relatively unavailable at the time. In terms of maternal ARVs, I think, again, the countries did well, with the exception of Tanzania, and we can relate this coverage in Tanzania to availability of CD4. Tanzania had the least facilities with CD4 available on site. For lifelong ART, Malawi had chosen lifelong ART because it was easy to implement and they didn't need, CD4 testing was not a precondition for initiation of treatment. So we can see if we look at the last bus there with Malawi in black or whatever color is showing on the screen there, we see that Malawi had very high coverage of lifelong ART simply because of the option they had chosen, whereas the other countries that had a precondition for eligibility for ART had very low coverage. Then we also looked at the 3 indicators I mentioned earlier for children. Generally, receipt of ARVs for PMTCT was quite high again, but there was variable coverage for other care and treatment services for children. And we looked at cotrimoxazole provision within 2 months and also testing of infants within 2 months. Testing of infants was particularly low in the 3 countries, that is Zambia, Malawi, and Tanzania. And this is not really a surprise, knowing what we observe even currently with regard to coverage of pediatric HIV services. The other component that we looked at is how are the communities engaged in service provision for PMTCT. So community outreach was common across all the countries with stronger involvement in others than the rest, particularly in Malawi and Zambia. So most often or more often countries use community health workers, volunteers, lay counselors, expert patients, or mentor mothers, and some with extensive really involvement compared to others. So there were instances, particularly in Malawi, also involving community leaders, traditional healers, and of course use of other media to convey information, and particularly cell phones for appointment reminders and conveying of test results. Referrals between communities and health facilities or vice versa was very informal, even though it existed, but mainly in a verbal form. There were, however, good examples of referrals in Malawi and Zambia in which there were pre-designed forms for use at the health facility or at the community level. And of course, record keeping is very important, and what we observed is that this was the last component that countries had considered, and not knowing that in terms of adaptation of guidelines also comes a requirement for additional information. So most of the countries, or all of the countries, were in the process of adapting the records or the registers, the monitoring forms, and so on. And therefore, a lot of information, particularly on pediatrics or those that related to postnatal follow-up, were hardly available. So what we observed is information generally on HIV testing was easily available. But when it went to information that relied on results that came from different sources, particularly where transportation of samples was done, such as CD4 and testing for infants, that is really where a lot of information was missing. Referral forms existed, and I've mentioned already there was not a formal mechanism of doing that, so the forms were hardly available. And a few facilities did improvise other mechanisms of recording information because this information was required at the central level, but they hadn't, really adapted the registers for them to be able to capture. And of course, not forgetting that partners often require almost 3 times as much information as is needed in the country. And all of the sites had an extra or 2 registers to accommodate the interests of the partners. So in summary, what was observable is that countries made considerations in terms of operationalizing the guidelines, looking at feasibility, cost, the ease of implementation, and the health benefits of adopting those guidelines. And we know that that is generally the pattern that should be taken. But they also had to make some strategic decisions, particularly in terms of adapting the guidelines in relation to the policies in the country. The capacity is very important to be able to provide and the essential commodities. And they were also definite proactive actions in terms of strategic shifts in how services were provided, and a number of countries were engaging or other lower cadre health care workers, particularly the nurses, to provide ART that was not traditional, and this required task shifting, therefore, to other cadre of staff. Decentralization to the lower health centers, because then they needed to reach more women, and different ways of supervision and mentoring, and of course, community involvement. So revision of registers always lagged behind, and it's something that seems like has not really impacted even in the new guidelines. So then we see Malawi that adopted a B+ option, really accelerating access to accelerating access to ART to HIV positive mothers, and without similar effects on pediatric HIV services. Again, reminding us that there needs to be integration of how we deliver these services without siloed approaches.
You have 1 minute.
Yes, this is my last one. Thank you. And therefore, a need, of course, also to have a family-centered approach so that we get services provided to mother and baby as opposed to mothers separately and babies separately. And community involvement, where it was strong, supported a lot of retention for women who are in care. So the importance, again, of paying attention to longitudinal follow-up of mother-baby pairs. And all the countries were in the process of pilot testing point-of-care CD4, and therefore point-of-care also for infant diagnostics, I think, is an important component that needs to be taken into account. So remember, this was a rapid assessment, and therefore not maybe capturing all the key elements. The timing was at a time when countries were very much in transition, and therefore it was not surprising that there was lack of some information that we were looking for. So that is just to acknowledge a number of people that were involved in the assessment, and thanks to all the countries that were able to provide us the environment to do this. Thank you.
Thank you, Dr. Priscilla.
Thank you very much. Our next speaker is another first author from the abstract, not the speaker listed in the program. This is Dr. Rosa Maria Bologna, pediatrician from the Garajan Hospital in Buenos Aires, who will speak to us about transitioning of HIV-infected adolescents to adult HIV care in Buenos Aires.